Welcome everyone to CoBody's first webinar. We've been doing a few seminars in clinic at the moment, but this month we thought we'd try something different. So this month we're focusing on irritable bowel syndrome. Just a quick introduction. My name's Aisha and I'm a dietitian here at CoBody. And just to go over a little bit of what we'll be covering today. So looking at what IBS actually is, signs and symptoms, nutrition, as well as physio management, looking at the low FODMAP diet in relation to IBS, and then fibre with IBS and just some overall gut health bits as well. But to start off, I think, what is IBS? And it's a little bit vague unless we've experienced it ourselves or work in healthcare. So to give you a bit of background, the IBS is one of the most common, what we call functional gut disorders. And this results in a range of different symptoms that generally what happens is it can't be explained by structural or biochemical abnormalities, whether that's via like colonoscopy or endoscopy. So we need to rule out a few other conditions before we diagnose IBS, but essentially it's a functional gut disorder. It's diagnosed using the Rome criteria, which is used a lot in research, but that's generally what we'll use in practice to guide our diagnosis as well. There is quite a big prevalence. It's affecting around, 10 to 15% of people worldwide. Women seem to be suffering at a higher rate, up to 1.5 to 2 times higher. And it seems to affect those under 50 years old a bit more, generally because by, that age or by, your mid sort of 20s, you would probably know if you're having some of these functional gut disorder symptoms. So there's a few different subtypes, and it's very much based on symptoms. To go into what that looks like, this would look at kind of the predominant bowel patterns that are happening. So IBS with diarrhea, which would be IBS-D, IBS with constipation, a mixed form or unsubtyped, but most commonly it would be one of those first 3. But I suppose what's important is, everyone experiences symptoms very differently, and they might not have all of the above, but there might be a combination going on. But it's really important to speak to your GP or healthcare provider if you are experiencing any symptoms. Generally, what we would use to track symptoms or to measure symptoms over time, once other things have been ruled out, would be things like the IBS Global Assessment of Improvement Scale, IBS Symptom Severity Scale, IBS Quality of Life Scale. And quality of life is really important as a measurement tool, just due to the impact that some of these disorders and symptoms can have on quality of life in every day, whether that's stress, having to go to the bathroom multiple times, or taking up like a large portion of our day, whether that's thinking or just suffering from symptoms. So a quality of life scale is really important. The personality inventory, which relates to sort of resilience and helps assess how an individual and their personality functions under stress. And we'll go into a little bit more as to why stress is a key part of IBS. And I guess that ties into a little bit around the gut-brain axis. And now that we've got a lot more insight as to ways in which the gut-brain axis and stress affects gut symptoms, we often incorporate methods around stress management when it comes to treatment as well. So a lot of these tools are quite common in IBS research. We do use them in practice, and they very much so guide dietary management and counseling as well. But obviously with all of these scales, you can see how this does get quite complex. So that's why it's really important to be working alongside your GP or healthcare provider when experiencing symptoms or being a little bit unsure and seeking a diagnosis. Looking at some of the symptoms that can commonly be seen in IBS, it's cramping, abdominal distension or bloating and pain, excessive gas, altered bowel habits, diarrhea, constipation, or both, or just it could even be looking at altered frequency of bowel habits. And then psychological comorbidities like depression and anxiety are quite prevalent as well. And just, again, going back to that link between the gut-brain axis as well, and I guess resilience and response to stress. There is what we call these red flag symptoms. And now this was something really important I wanted to note, because a lot of conditions, particularly gut conditions, there are quite a lot of symptoms that overlap with symptoms of IBS, and that might be stomach cramps, bloating, and changes in bowel habits. So we call this process ruling out the red flags, just to make sure the patient's symptoms aren't caused by anything else. Some of the symptoms might be like having blood in your stool, sudden changes in bowel movements, unexplained weight loss, or having a new onset of these symptoms after, like, say, 50 years of age. It might be a family history of colorectal cancer, inflammatory bowel disease, or celiac disease. It's quite important that we do rule out these other conditions prior to testing or treating IBS. Just regardless of any of these red flag symptoms, it's still probably best to have other things ruled out first. And you'll find that does commonly happen in practice, whether it's ruling out IBD or celiac with a gastroenterologist as kind of like a first step. Just to have a look. Oh, okay. I'm going to hand over to physio just to go over how to kind of support IBS with physiotherapy.
Hi, I'm Shanae. I'm one of the physios at Co-Body Wellness Studio. I just want to jump in and talk to you a little bit about the link between IBS and physio and what physio can offer. So IBS isn't just a gut disorder. There's an actual link between core dysfunction, breathing patterns, and nervous system regulation. So many people with IBS also experience chronic back pain. So why is this? So let's look at core dysfunction and spinal stability. So the core and the digestive system actually share the same space. You've got all the core muscles surrounding the abdominal organs and things like that. What can happen is if there is any inflammation, there can be extra pressure and dysfunction up against those muscles. So the muscles aren't able to work as effectively. If you think of it like a binder, if there's inflammation or pain or anything like that, and on that other layer, what happens is the core muscles don't work as effectively. And this can actually lead to a dysfunction, meaning they don't work as well, which can bring on things like back pain and things like that. Often what happens is there's bloating, cramping, and inflammation, or maybe excess gas. So you're thinking like your core itself doesn't want to do its job as effectively when it actually needs to. So we just look at the diaphragm, breathing, and gut motility now. So the diaphragm connects breathing, digestion, and spine. If you've got poor breathing biomechanics, there can actually be a reduction in gut motility, which puts excess pressure on your spine. So if you imagine you're not as effective at breathing, it means that your whole nervous system is heightened as well. So that leads us to the link between the vagus nerve and stress response. So the vagus nerve is cranial nerve 10, which is actually involved in controlling that rest and digest system, but also controlling levels of inflammation in the body. What can happen is, because IBS is a chronic stress on the body, it keeps the nervous system in that fight or flight mode, which can actually mean our whole body goes into that stress response. You've got tense through the core, slow digestive system, tension through the upper shoulders, and things like that. So how can physio help? Well, diaphragm breathing can support core stability and function. So we can help teach you how to do this effectively and look for ways that your body isn't working as effectively. Manual therapy, so releasing techniques, release techniques that are involved in releasing your abdomen, like underneath your rib cage, back, and your vagus nerve, which comes up to your neck. And then also targeted movement, so looking at gentle core activation, exercises, spinal mobility, things that are going to aid in pain relief and digestion. I'll hand back over to Aisha.
Okay. just going on to the pathophysiology of IBS, which really just talks about sort of the etiology or the root cause. And you can imagine kind of understanding a little bit more about the complexity and diversity of symptoms in IBS. That does make it very challenging to understand its exact cause. And to be honest, research doesn't really show any definitive answers yet. Several sort of theories have been proposed, and that includes visceral hypersensitivity within the gut, altered gut motility, as Shanae was just discussing in relation to physio, disturbances of the gut-brain axis, which we talked about earlier, namely it can be sort of like stress or a trauma-induced sort of response through that system, an altered gut microbiome or dysbiosis. And to date, we don't really know if dysbiosis is the cause or the consequence of IBS, or just a bit of a negative loop there. So something to consider if you do have symptoms. There is a high prevalence of SIBO and clinical response to microbiome targeted therapies like antibiotics, which are often used for SIBO treatment. And antibiotics, as we know, definitely has its role, but can have a bit of a negative effect on the gut microbiome overall. So just things to keep in mind when thinking of root causes or where it's come up for you, and maybe things that you've experienced, whether that be SIBO or excessive use of antibiotics over your life, or a highly stressful job, whatever it might be. Overall, something we do know is that IBS patients have a reduced density of endocrine cells. So this causes kind of in part gut dysmotility, that visceral hypersensitivity that we were talking about, as well as abnormal secretion from the gut. And I guess just a note on visceral hypersensitivity and what this kind of actually means, just refers to sort of an increased sensitivity to pain or discomfort in the gut or the internal sort of gastrointestinal system. People with this condition, like normal activities like digestion and gas moving through the intestines, can be painful or uncomfortable, even though this is like quite a normal process and wouldn't bother most people. It's very common in conditions like IBS to have that increased sort of hypersensitivity within the gut. So thinking about nutrition management. So it can get quite complex. We usually would recommend a stepwise approach to making sure we manage symptoms versus just having a bit of a blanket approach. So with the stepwise approach, we always want to prioritize nutrition strategies first before considering pharmacological strategies. Not that there's any sort of first line or gold standard in terms of medication, which is another reason why nutrition is so important in those early stages. But a recent study actually showed that FODMAP lowering diet was actually more effective than standard medical therapy in alleviating IBS symptoms. So nearly 2/3 of patients with IBS perceive their symptoms to be food related. So you can imagine how food and nutrition, along with some of these lifestyle tips in relation to sort of stress management, has the biggest role in IBS. And when you think about it, that makes sense with all that we do know now regarding the gut-brain axis and the gut microbiome within research as well. So when we talk about the low FODMAP diet, I think the most common question is, what is a FODMAP? And it's a very, very interesting acronym for some very long names. But essentially FODMAPs are the oligosaccharides, which is like your fructans. It would be, the fermentable oligosaccharides, your disaccharides, monosaccharides, and polyols. And there's a few others within that, like within polyols, there's sorbitol and mannitol, which is found in some fruit and vegetables. Disaccharides might be lactose found in dairy products, and oligosaccharides are some of those fructans, fructooligosaccharides, as well as your there's a lot of long names, but galactooligosaccharides is another. These are all very normal sort of types of different carbohydrates found in foods, but for people with IBS, they tend to be quite sensitive to either one, some, or all of these FODMAPs. So these short chain carbohydrates, they're typically poorly digested or absorbed, in the small intestine. So instead, they pass into the colon, where they get broken down through a process called fermentation, acting as food for the gut. So this is usually it's actually quite a good thing. Fermentation in the gut of fibers and is actually how we feed good bacteria. But in this fermentation process, the microbiota naturally produces gas This leads to bloating, again, can be quite normal, but because FODMAPs are poorly absorbed, and more so in those experiencing IBS, significantly more so, they linger in that small intestine, and through an osmotic effect, it tends, like these FODMAPs tend to draw excess or more water into the gut, and this is where a lot of that abdominal pain, bloating, and sometimes diarrhea would come from. Looking at the specifics of the low FODMAP diet, which obviously kind of incorporates that FODMAP, those FODMAP foods. So it has quite a good effect rate, particularly in comparison to any other strategies that have been looked at so far. So 60 to 75% of patients with IBS do see good results. It's generally a 3-step protocol of elimination, reintroduction, and then personalization. Usually benefits can be seen within the first 2, but up to, usually around 8 weeks when we start reintroducing and personalizing the diet. Our goal as dietitians, though, is to really ensure that the low FODMAP diet does not become an elimination diet per se, even though there is an elimination phase, but rather looking at it as a substitution diet. So where we might, yes, have to eliminate FODMAPs in the early stage, but making sure we're able to kind of replace these to make sure patients are getting adequate nutrients. And, fiber is a very important thing, and a lot of these do contain quite a bit of fiber. So we try to look at it as a substitution diet where we switch, like, say, the daily apple for an orange, or onion for chives, or whatever it might be, because everyone's sensitivities and tolerances are different. It is very much designed to be a short-term protocol because of the reasons I've just mentioned. And that's kind of why, if it's not done alongside a dietitian, in addition to it being already quite a complex sort of structure and diet and foods, you need to kind of have that kind of guidance and proper nutrition education, because it can become overly restrictive and actually quite hard to do properly, because it can appear to be quite restrictive if you don't really know what to replace with things, or I suppose where to get your information as well. And there's a few good tools a lot of dietitians would be familiar with, and that's like some of the Monash resources and things like that. But really what we're aiming to do is avoid long-term restriction. This, like I said, just because of that lack of fiber mainly, doesn't have a good effect on the microbiome, and just overall nutrition status and well-being of the patient. We don't really want to take that restrictive or overly restrictive approach. There are a few different approaches we can take, like depending on the symptoms and any co-occurring conditions that a patient might have. There are some softer approaches to the diet, depending on a patient's nutrition status or their relationship with body or food. This is something that should be considered if there are any other sort of red flags, or just, things that might contraindicate the ability of a person to kind of be overly restrictive or restrictive in those initial phases. It might mean that we need to look at really honing in on the foods that we know for sure cause symptoms and just focusing on those, rather than having a whole blanket approach to all FODMAPs in those initial stages. But this is why I say it's important to work alongside someone that kind of can guide you, because everyone's experience will be different. Everyone's ability to kind of successfully do the diet and manage symptoms will be a bit different. And I think this has to be maybe one of the most challenging ones to do, I guess, in terms of, dietary management, even though it is short term. So yeah, important to seek some help with that as well. And then just looking at fiber and IBS, and we've talked about fiber a little bit already, but also just specifically in relation to gut health, I don't want to forget it. Overall, adults are meant to be having 25 to 30 grams per day. Not many adults do meet this, but particularly fiber can be a bit of a tricky one for those with IBS. So daily intake will depend on or your ability to meet fiber intakes will depend on your symptoms or the severity of the IBS. Just to look at, I guess, different types of fiber. So insoluble fiber and soluble fiber are the main ones. Insoluble fiber doesn't dissolve in water. So this one tends to add bulk to stools and increase transit time through the gut. So it helps keep people regular in terms of bowel habits and prevent constipation. It's generally found in like the outer layers or rough parts of plants like fruits, vegetables, and whole grains. But soluble fiber has actually shown to be really important in IBS symptoms. So soluble fiber kind of the opposite, actually does dissolve in water, whereas insoluble fiber doesn't. But so soluble fiber dissolves in water, forming a gel-like consistency. This helps kind of soften stools and delays transit time rather than increasing it in that insoluble fiber. And this helps manage kind of both constipation and diarrhea. So insoluble fiber doesn't seem to have benefits yet that we can see in treating symptoms of IBS, and sometimes it actually might make them worse. So this is why, again, just IBS symptoms and dietary management is a little bit complex, particularly when it comes to something like fiber, because fiber for the general person is so important, and both types have great benefits. But for those with IBS, it might be that we need a little bit more tailoring and personalization just around those fiber types and amounts that we're having. So insoluble might not be helpful for those with IBS-C, symptoms. Of all kind of the soluble fiber categories that we do want to include in IBS, the soluble, viscose, sort of low fermentable fibers, and this is things like psyllium husk, inulin, beta-glucan is like a nutrient in oats, and these have shown promising kind of results in improving things like bloating, gas, abdominal distension, which is another kind of word for bloating, and the fecal or stool output as well. So ways to increase soluble fiber intake might be adding 1 to 2 teaspoons of psyllium husk, chia seeds, flax seeds into coffee, smoothies, breakfast, oats, or yogurt. Trying to keep the skin on fruits and vegetables, and adding beans and lentils and peas to your weekly rotation in either salads, replacing meat, or whatever it might be. But again, just being mindful that a slow approach and is always preferred, no matter the person. Generally, if you're having quite a low fiber intake, your gut might need time to adjust, but particularly for those with IBS, start low and go slow. Increasing fiber can be helpful for IBS symptoms, but we do need to be a bit strategic about it. Psyllium husk, though, is one thing that has, is pretty well tolerated across the board and very easy to add. It's a soluble fiber, so it could be a good place to start, and other fibers just might need to be a little bit more trial and error. That was all of our information on IBS. If you have any questions, please feel free to reach out to the team, and we can answer anything for you. Thank you for coming.